Yes, sir.
Good evening to you all. Today I am going to discuss a very exciting topic, a topic of a subdiscipline of ear, nose and throat surgery. Correct the function of the nose, the airway which we give, along with that any other abnormality on the nose which is very glaring to the patient, we will correct both at the same time so that when we get a mastery over this surgery, then we will have the satisfaction of giving not only social, psychological as well as functional advantage to the patient. So physiognomy means the appearance of the face. In the nose occupies the middle third of the face. It's a very prominent part of the face. The moment you see somebody, it is the nose which strikes you. So previously, during our development, the type of nose, the size of nose and the appearance of the nose was supposed to give an honor and character. And because of this type of behavior, this type of attachment of the nose to the character, the person tends to get attracted whenever he is having a social interaction, so that the person is indirectly ascribed to the nose, which may not be so always. Sometimes some people, when they try to read the character of the person from the face, they say that such and such a type of a shape of the nose, the person may be behaving like this, which may not be so. So there is an aura around rhinoplasty in which the surgery is not really taken up very well because the results are shown on the face of the patient. So a good, properly performed rhinoplasty will give so much satisfaction that the result, because it is shown, there will be some sort of apprehension to learn the surgery. So this apprehension can be overcome by learning what exactly is what we want. So this type of triangle around the aura of rhinoplasty is what we are trying to achieve. Why is this aura around rhinoplasty? Is it a science or is it an art? In which you will learn measurements, angles, the lie of the nose. But as you keep doing it, you get so much info, and the results you get mastery, then over a period of time, art where the beauty of the patients is restored, enhanced, so that he'll have more satisfaction and can interact, and then his achievements will be more. I call it a revealed operation, which the results are to the attendants, to the patient, and to the surgeon himself. And as the time goes by, the results will become so enhanced. Such once we do a surgery properly with our satisfaction, you feel like doing it more and more because the results are easily. The around this surgery can be overcome. Wound closure is what I call as a signature of a surgeon. The properly done wound closure, what has happened inside, it has happened good. This is a patient who had got an incision on the neck. You can see the wound here. Even though the wound is on the neck, the patient may not give so much importance to it because it is not seen directly by anybody. This can be covered. However, a badly done rhinoplasty will give so much problem that the beginners may become apprehensive to learn the surgery, or while in the learning phases, the results, if they are not good, then we may go into a cocoon or a shell so that we don't want to explore again. However, as human beings, we have to learn it again and again so that the results will become better. So it has a long learning curve. Long learning curve, the amount of time you dedicate, the amount of time you give to learn the finer aspects, and once we get a good to do more. So is the left. On the right side, we can transform. This is the result after about 3 months. And after that, the patient is lost to follow because he's happy with, he's able to breathe and is happy with what he has got. And this is another girl who had come with some deviation. And on the right side, what we have achieved. A person with a saddle nose, which we call on the left side. On the right side, that is the result. You can see the shining lines, which I'll come to again. The 2 lines on the nose here. This is another girl. Now you see the change in expression of the eyes. it is the same eyes on the left and right side, but a small elevation of this nose here to here has made the change in that. So when we get a satisfaction like this, there is a impetus to learn it more. So before we do any correction of this sort, we have to assess the nose properly. In that assessment, so there will be some terminology called as trichion. This is the points on the face. Glabella is the forehead. Then the nasion is the tip here. Rhinion is the middle part of the bridge of the nose. This is the supratip, and this is the tip of the nose. Subnasal or the lower part of the nose. Upper lip, the labral superior. Opening of the mouth is called stomion. Lower lip called labral inferiors. Mentolabial sulcus. Conion is the prominent part of the chin. The chin as it meets the neck is called as menton, and this is the cervical point. So we have a different terminology for this, which we have to learn one by one. So for what is the anatomy of the nose for rhinoplasty? For the nose, as we can see, this is the dorsum of the nose, this is the tip, columella, upper lip, lower lip, then this is called as the nares, the opening. This is this structure which we easily see. The nasal bones are the ones which form the upper third of the nose. Then the middle third is formed by the upper lateral cartilages, which are attached to the septal cartilage. Then the lower lateral cartilages are 2 in number on either side. Upper lateral cartilages right and left. Nasal bone left, nasal bone right on the other side. This nasal bone is attached to the maxilla here, called as nasomaxillary suture. This is the nasal process of the maxilla. Then there will be a frontal process, nasal process of the frontal bone attaching to this here. This is the nasofrontal suture. So this depth, this elevation, this dorsum, this lower lateral cartilages are all bearing on the shape of the nose. Once we learn this internal anatomy, then we will know which part to correct. So then there is another area called a soft triangle, which is present in the lower part ala of the nose, where there is no important cartilaginous of the skin. So this is the area which gives a pleasing appearance to nose, more particularly in females. And this girl has got a soft triangle here, which is little more accentuated compared to a normal girl. And this has to be taken care of because during external rhinoplasty, when we give an incision here, and while suturing, we should not damage this normal notching. Otherwise, if the suturing is done, there will be a notching which may be apparent to the patient. Then the middle part of the nose on either side is the septum. So the septum is the one which lays the foundation for a proper nose. As goes the septum, so goes the nose. The central septum is essential for a proper nose. And when we come to the parts of the septum, you can see this is a sagittal section. This is the frontal sinus. This is the nasal bone here. Then this is the upper cartilage, the nasal bone. And this is the perpendicular plate of ethmoid, articulating with vomer behind. This is the palatine crest. This is the maxillary crest. Then there is a small projection of bone called as anternasal spine. This is the cartilage of the septum proper. And sometimes there is an extension of this cartilage through posteriorly, articulating with the bones above, which will lead to spur either here or here. Then this is the lower alar cartilages. The medial crest forms one boundary of the sagittal section here. So this is the lie of the septum in the center. And I have a model for rhinoplasty, which I want to share with you. So I think you can see that I am holding a calendar, and as the dorsum of the calendar. If it is straight, then the septum is straight. If there is any crookedness of this calendar like this, then you can see that the whole septum, I am separating the lateral wall of the nose, the skin part of the nose. If you have a curvature here, see how the pages inside the are also getting curved. So whenever we see a nose which has got an external deviation, unless you correct the external deviation straight, this septum cannot be straightened. So at this time, what we have to learn is what we have to learn is the external deviation of the nose should be corrected whenever there is a septal curvature inside. If the septum is deviated, if the outer border of the dorsum of the nose is straight, then that can be corrected by a simple septoplasty. Otherwise, whenever we see a deviation, we have to do septoplasty and rhinoplasty at the same time. Otherwise, the deviated nasal bones will again make the corrected septum, which we feel we have done properly, will go back again to a curved septum. So this is the basic anatomy of the nose. Now we'll come to the proportions of the nose and face, which defines a proper nose or an abnormal nose. The beauty of this face is if you draw a line along the hairline, which is called at the level of the trichion, which forms the upper line, and another line at the level of the root of the nose or the glabella, it divides the face into 1/3. Another line drawn at the level of the base of the nose and another line drawn at the chin. So it divides the face into 1/3, 1/3, 1/3. This was propounded as early as 15th century by Leonardo da Vinci. So this proportion, if it is accepted, then it looks pleasing to look at. In addition, you can draw 6 lines, one at the level of the medial canthus on the right side, line along the medial canthus on the left side, line along the lateral canthus on the left side, line along the pinna of the ear on the left side, similar line on this side. So you can divide the face into 1/5, 1/5, 1/5, 1/5, and 1/5. See, the beauty of this division is the nose, the ala of the nose on the lower part occupies this area. So the proportions. So whenever this pleasing proportions are disturbed, then it becomes a little difficult to look at. So the patient feels that there is something, either it is too broad or it is too narrow. And then we have what is called as types of noses. The types of noses is dependent on physiological basis. And the physiological basis depends, gives rise to the proper shape of the nose. Nose, as you know, is an organ through which we inspire, we expire. The humidification of the nose, humidification of the air is the function of the nose. So whenever somebody is there in a very hot environment, and if that hot air as it is going inside may create a degree of warmth or heat in the nose. So people living near the equator will have very broad noses. People who are away from equator in very cold area, the cold air should be humidified and the air should become warm. Tall nose in people who are living away from the equator. That depends on the shape of the nose. So the shape of the nose is divided into what is called as a leptorhine nose, a mesorhine nose, and a platyrhine nose. Platy means flat, meso means in between flat, and lepto means very thin, narrow, long nose. So when we can see the length of the nose here, the length of the nose here, and the length of the nose here, you can find out that because of geography, this type of face is ascribed to an Asian or an African because they reside in hot air, humid air, so that the air ingress should be more, air exhalation should be more, much more quickly. Whereas a nose of this type we see more in cold climates because the cold air will cause the airway, air passages to wait for some time in the nose. So a leptorhine nose we'll see in a narrow nose. It will be a projected nose because of this laterally compressed nose. They are seen more commonly away from the equator and they are called as Caucasian noses. A mesorhine nose is called as a Mediterranean or a Latin nose, more nearer, little away from the equator. The dorsum is moderate and there are little wider noses compared to leptorhine. And a platyrhine nose is a widest nose. It allows more air during breathing. Nearer to the equator we can find. So the alar flare, that means the projection of the nose beyond the medial canthus, in this type of nose it should be considered normal. So they are seen more commonly in African and Asian areas. So what is the differences in rhinoplasty because of this? A Caucasian nose has less subcutaneous tissue. Because of this, if we do any surgery on this, the results are seen much more easily. Whereas in a platyrrhine nose or an Asian African nose, because the subcutaneous tissue is much more, whatever correction we do may not be apparent to the patient, the results of surgery. So in a perfectly done rhinoplasty in platyrrhine nose may not give as much manifestation post-operatively compared to a Caucasian nose. What is an Indian nose? Because India has been invaded by so many races at many points of time, and the mixture of all the descents of the people who came to India, we have a mixed nose, and this mixed nose depends on the area from where the majority of the time the patient is coming from. In the north, Kashmir, Punjab or Himachal Pradesh areas, you can find a typical leptorrhine nose. If we go to the northeast and the south, you will find a platyrrhine nose. So the races and the areas both have a to the rhinoplasty assessment proper from the front. When you see the patient, before we look at anything, we have to look about the facial asymmetry. Inherently, right and left side in some patients may be having some minor differences in which the right side of the face may be little more, or the left may be little more, and the right may be little less. In those conditions, if we try to do a proper rhinoplasty also, if this is not detected beforehand, the patient may become little dissatisfied. So before we assess the front of the face, we have to see whether it is symmetrical properly, proportionately, or if there is anything different. By taking a proper photograph, the results may be guarded. So we have to caution the patient that this may be has a role in results. So we draw a midline strictly in the center, compare the distance from this medial canthus to this medial canthus, right and the differences in the lips. As once we are aware of this condition, we should keep seeing wherever it's possible, either in the OPD or in the television or in the social media, wherever you are seeing, you can pick up this sort of asymmetry once this is known. Then we begin the assessment of the nose. So people have drawn a line, the brow and the nasal tip are connected by a line. This is called as a brow tip line, or it's also called as a dorsal aesthetic line. So this dorsal aesthetic line gives this shining of the light when it is projected on the patient. So this will be usually parallel in a given nose. So the lighting has to be perfect when we are taking photograph so that these sort of distortions will not be manifest. So this is the brow tip line. Middle canthus will touch the ala of the nose, which is equal to the distance between the medial canthus on right and left. And this is also equal to the medial canthus on right to lateral canthus on the left. So this proportion is called as bone base ala base width. And 70% of this, when you draw it along the lateral margin of the nose, bony lateral margin of the middle third of the nose, the line drawn should be 75% of the LR base width. So this is a proportionate nose. This is the dimensions in which if the nose is situated, then we can call it as a proportionate nose. Then on the tip of the nose, we see two shining points called as tip defining points. So this is a tip defining point on the right side. This is created by the dome of the lower lateral cartilage. Another tip defining point equal to the distance between the two brows. So this is the proportion which we have to aim at. So next, coming to the shape of the nose at the lower part, this is called as gull in flight. This is the shape of the nose called as gull in flight appearance, and this will show the philtrum. Otherwise, if it is depressed, then it will come down like this, or if it is over projected, then we can see the nasal cavities. In a lady, because they are shorter, if it is little above also, it's not much of a problem. But in those who are having tall height, if the tip is receded, then it shows the nasal cavity, which may not be acceptable. Coming to the lateral view, what we see is called as a 3-4-5 triangle. So the amount of nasal projection should be equal to 60% of this dimension, the root of the nose, the base or the ala of the nose. So this should be 60%. If it is less than this, then it is called as a drooping tip. If it is more than this, it is called as a over projection. A over rotated tip, a normal or a drooping tip. So in this picture, you can see that this distance is 1:1. This is more than 1:1. This is less than 1. So this is an under projected, normal, over projected tip. So this dimension is given by the size of the lateral crura, the medial crura of the lower lateral cartilages. So whenever you see this assessment, then the alar cartilages have to be correct. So this is an example of a girl who had come with nasolabial angle, which we'll come to. Then you can see the drooping tip. So actually it should be about 95 to 110 degrees. When you go to the lateral view, we'll get what is called as a nasofrontal line, a line drawn along the other line along the dorsum of the nose. This angle is 115 to 130 degrees. So this is labella, this is, if is then we'll get over projected nose, or there can be an under projected nose, depending on that. So acceptable one is 115 to 130. Then the forehead will also change the shape of the forehead, will make the nose appear longer. A normal one, this is normal. The three dimensions of the nose are same, but this type of forehead will make the nose appear small. This type of forehead adequate. This will appear little longer. So this is a lady who had come with a nasal dorsum, but there is a concavity because of previously done surgery where there is a saddle because of the cartilaginous part of the nose is destroyed. And there is another angle called as nasofacial, in which you draw a line along the dorsum of the nose and a vertical line touching the forehead. And this is a proper alignment to the nose called as nasofacial angle. Of the nose is rotated up, normal or drooping. So this is 90 to 115 degrees. In a lady, you can go up to 110 degrees, but in a male, it will be 90 to 95. Ill-defined nasolabial angle, which needs, how do we correct it? We'll put a cartilage here, strut here, so that the tip comes anteriorly and then the nasolabial angle is opened up. So there is a double break in the columella. This the lower recedes and then it meets this part of the nose called as columella. This is a double break, which is a pleasing shape of the nose. And moreover, in addition, we will be seeing 2 to 4 column compared to the nasal cavities. This is called as columellar show. If it is not visible, because the ala is either drooping down or the columella is receded whenever this part of the nose is not developed, and it causes the nasolabial angle to be decreased in. Then coming to the base of the nose seen from below is also, in this you will have 1/3, again 2/3. This 1/3 is called as lobule of the lower of the base or the nasal tip lobule. Then this lower 2/3 is formed by the medial crura up to here, and then there will be fibrous tissue, connective tissue, which will insert into the antenasal spine. This is an equilateral triangle, and if there is any caudal dislocation of the septum, you can see either right or left, and if that is there, then the nasal harmony of the base of the nose is altered. So the lining of the skin covering all these parts have to be studied in total. So there is varying thicknesses, and the role of skin, as I told you earlier, thin skin will give good results, but if there is any irregularities or any corrections which are not done properly, may show on the face. So the skin, as you know, is thick at the root of the nose, thin at the bridge, and again thick and sebaceous at the tip of the nose. So this aspect of the skin thickness should be identified by palpating the nose before operations. Then we have to document the shape of the nose before operation to find out what are the things which can be corrected, what are the things which cannot be corrected, to get a proper assessment and give the patient a realistic assessment of the result. So we'll know, it gives you a comparison and the expectation of the results which can be achieved. So for this, we take a frontal view of the patient, right and left profile views, lateral oblique view, basal view, top view, and lateral view while smiling. Because this lateral view while smiling is important because there is a muscle called as depressor septi muscle. So when the patient is smiling, it contracts and it leads to change in the shape of the nose. So some people, they say that when they are smiling, the shape is changing and they don't like it. For that, you have to cut the slips of the muscles so that when they are smiling, the nose is not pulled down. So for photography, we have to take a standard photography with a 35 mm DSLR camera. With mobile camera nowadays, patients are taking photos and coming to us. The standard situation is a film speed of 120 or 125. Reflected lighting over the patient. Otherwise, if the lighting is too glaring, then some parts will be accentuated. There can be shadow of the nose on one side. If it is reflected covered lighting coming onto the face of the patient from right and left, then there will be total illumination. Then photograph will not show any distortions. Background at the same time should be non-distracting. If a patient or we take a photograph with a mobile camera, there is what is called as a fisheye effect, in which some parts of the nose face may be distorted, some parts may not be correctly magnified. So then what happens is we will not get the proper proportions. Then when we are taking photography, we have to take the consent of the patient for the photographs, whether we can share the pictures. So we should not take pictures of the patient without their permission, and we should not share it because over a period of time he may become a celebrity, or a celebrity may come to a surgeon, and then those should not be shared without consent. And I also request you, some of these photographs, please don't take. Then, as I told you, in physiognomy, the nose is the prominent part of the face. So wherever the person is going in social settings, talking to somebody, he may be having some sort of attachment to the shape of the nose. So they'll ascribe something. If somebody is failing or somebody has got some problems with the psychosocial adjustment, they may ascribe some type of situations to the nose, and then they may come for some surgeries or some complaints. So in those aspects, you have to be very careful. As a lay public, it is quite possible because of their upbringing. So then there is a condition called as body dysmorphic disease. In this, mostly in females between the ages of 17 to 25, they think that there is some abnormality in the nose which is hindering their progress or which is not making them more successful what they are. So because of that, they will be so much attached to the nose or to other body parts, then they may come for some alterations. And this is something we have designed so that we can predict the results of computer scan on the CT scan of the patient. So this was a patient who came with right-sided nasal deviation. Then these are the views which you have taken. They are fed into a computer, and then we can see the picture changing on your top right side, showing the underlying nasal bones. You can see the deviation of the antenasal spine here, which we can give guidance, what surgery, which part you have to concentrate on. Then this is another one where you can see the deviation on the CT scan, the patient's deviation, and this deviation here. So this is a study which we are doing, and then you can get a hologram of the patient showing the interior of the nose, and this is the interior of the nose. You can make out the deviation from inside. What is the length of the nasal bones here on this side and on this side, the distances here. So this has to be analyzed, and for this Dr. Rahul Kumar has helped me out. And then the expectation of the computer data is the patient will have that he should have a perfect nose, which may not be possible because of soft tissue abnormalities, the scarring, the previous skin, and one side the nose may have more skin compared to less, and the tendency of the tissues to go back to their original after surgery. Then the functional cosmetic relations of the nose have to be assessed by the interior as well as the exterior. The interior, as you know, will do the direct diagnostic nasal endoscopy to find out the deviations, to know the amount of nasal deviations, high septal deviation, and the deviation of the lateral nasal walls or the hypertrophy of the inferior turbinates. All these have to be checked to get a complete total surgery. Then after all these, we'll get noses like this. In the center, on the left side, you can see a perfect nose, which may not be possible always. You can see a nose like this curved from right, and a nose which is S-shaped, and a nose which is completely deviated to one side. So a patient can have a nose which is upper third deviated. Because of this deviation, the other part is also gets deviated along with that. Then there can be a major deviation with a hump on this, so that this has to be taken care of during surgery. Then the tip also has to be addressed. The girl only has got abnormalities of the lower velar cartilages. This has to be assessed. This is because of the dome on the right side. This is the lateral crura. This is the middle crura. This dome, you can see the asymmetrical domes. That has to be adjusted again. Then there can be a crooked nose, a saddle nose, broad nose. So a person with a deviated nose, C-shape along with the septum, the nasal exterior also is deviated. This type of nose, we cannot correct the septum without correcting the exterior. So Rhinoplasty is the one which is minimum needed for this patient. This is a patient who has got a very broad nose, where the dorsum is not defined. There are no aesthetic lines. There are no tip defining points. And the ella of the nose is projecting beyond the medial campus. So this is the medial campus. So this is the amount of flare, velar flare. So we have to cut the bases and then pull it together and create the dorsum. So this is a patient who has got multiple deformities. Dorsum is not formed. Notching is there in the soft triangle area. The columella is completely receded. The ala is projecting out. Another patient who has got a dorsum of the nose not formed. There are no dorsal aesthetic lines. Then this is a congenitally bifid nose given to me by my professor, Dr. Anand. So this needs complete total reconstruction of the nose. So the internal anatomy of the nose I told you. Then there are, to do all these corrections, there are two types of operations. One is external or open, another is internal or closed. The internal or the closed one is, it is called closed because the skin is not detached totally from the columella and from the dorsum. There will be a hanging under cover of the skin. All corrections are done. In external rhinoplasty, the columella is detached and then the whole skin is lifted up like an elephant trunk. Elevating the skin cover of the nose is called external. Closed skin is not elevated totally. Skin is attached at the columella. So under cover of skin it is done. So closed or internal rhinoplasty is also called as. Closed does not mean that it is totally blind, but you can reflect it up. Jacques Joseph is the one who did the first closed rhinoplasty. And the incisions in closed rhinoplasty are within the cavity of the nose since they are invisible. So what are the types of incisions for closed rhinoplasty? It's called as the hemitransfixation, full transfixation, intercartilaginous, intracartilaginous, marginal, and there is incisions for osteotomy in the anterior to the inferior turbinate in the internal cavity of the nose. So this is an incision along the caudal border of the septum, which you have to extend on both the sides so that the interior of the nose is elevated, the skin is elevated, but at this area it will be continually attached. So this is what I was talking about. So this part is retracted, it is cut from right to left, and then We'll give a marginal incision at the lower border of the LR cartilage and another marginal incision between the lower LR cartilage and the upper LR cartilage so that the cartilage can be taken out, and if there is any dual abnormality that can be corrected under vision and it can be repositioned back. And through the same incision, if there is a bony hump, that can be removed with an osteotomy. Then this is a photograph showing what are the types of resections of the LR cartilage. If the dome is very prominent, this part of the nose, this part of the cartilage will be removed, or a part of this cartilage is removed. You have to leave behind 8 millimeters of this cartilage. Otherwise, there will be LR retraction and LR collapse. So the two deformities are done by this surgeries. Then the septum attachment. As you know, the septal cartilage, this is the pericondium, this is the metapericondial tract which envelops. So why this diagram is, when we are doing the septoplasty, sometimes if there is a deviation, if we try to go inside, there will be a tear which causes a tear and a synechium. So what we have to do is we have to cut it by sharp dissection so that this is elevated on one side, periosteum is elevated on the opposite side, any extra cartilage is cut and the septum is positioned in the center. Then for lateral osteotomy, an incision is given just anterior to the inferior target, and through that there is a guarded osteotome which will go inside and make an osteotome. There can be a high to low to high or a low to low to low. So depending on the type of deviation of the nasal bones, we have to do that osteotomy to get the proper alignment of the nose. So what are the steps of rhinoplasty? We have to uncover the nasal framework of the skin, remodel the nasal tip, shorten the nose by removing a part of the cartilage either dorsally or caudally, remove the nasal hump, then repair of nasal septal defects if indicated, narrow the nose, splitting of the nose, and postoperative instructions are to be given. What are the advantages of closed? Even though it is not very popular nowadays, now it has come back again into vogue. The skin contact is maintained in the lateral part so that the bony fragments can be aligned much more easily. The dissection is less. In external, the dissection is more. The alignment of the osteotomes after correction is good. Then postoperatively, the edema is good. Edema is less. And the patient will have what is called as a natural look of the nose. He does not have an operated look, and he doesn't have operated nose job done type of picture. So postoperative results are seen early, because if you do external, the results are seen late because of edema. The disadvantage of a closed rhinoplasty is exposure is supposed to be less. It is in some places blind, but the feel of the instrument on the bones and on the cartilages, it can be learned, and that can be taken as a guidance as they keep doing it more and more. Then the learning curve will be improved. Grafts are liable for displacement as they cannot be fixed by suture. So while making the graft placement, the elevation of the skin should be less, the pocket should be less, so that the graft does not move. It is little difficult to learn, and it is little difficult to demonstrate because the elevation of the skin will be hampering the display of the structures like the upper lateral cartilages, lower lateral cartilages. Another thing which is supposed to be done is the spreader grafts, which are to be kept between the lower lateral, upper lateral cartilages and the septum in case of narrow nasal angle, cannot be aligned properly when we do a closed rhinoplasty. However, it can be learned. So to overcome all this, there is what is called as external rhinoplasty, in which we give a mid-columnar incision, then elimination of the dorsal of the skin covering is done, exposure of the septum, correction of the hump, septal deviation correction, osteotomies to correct the nasal wall deviations, tip corrections, and closure. These are the steps which are done. This is the mid-collar inverted V incision, or also called the rapid incision, in which an incision is made on the column. And in this, once we make an incision, the medial crura will be just underneath the skin. So there is a chance of it getting damaged. So when we are elevating this area, then it has to be taken care of properly. And once the elevation is done, we can see that the septum is displayed. In this case, there is a severe curvature of the septum. So the septal dissection has to be done between the domes of the lower alar cartilages from above downwards. So the advantage is we are not entering the cavity of the nose. So the nasal cavity is not injured at any point of time if properly the elevations are done. Once the septum is corrected, then the deviated parts are removed. The extent of the cartilage is near the tip and the follicula is greater. The deviated part of the cartilage is removed for proper placement of sugar graft or any defect which is necessary, which means the graft can be harvested from the septal cartilage. So once that is done, then this part of the lateral nasal wall, which is causing the deformities which are shown in the preoperative analysis, can be done by what is called as a percutaneous nasal osteotomy, in which a small incision is given. This incision need not be sutured because it is so small, postoperatively it will not be visible. So this 2 mm osteotome is inserted and it is made a cuts along the nasofacial groove, so that these are detached by using a osteotome and a hammer. Then the nasal part, nasal bones gets separated from the lateral nasal wall. It has to be high to low to high or low to low to low, depending on the necessity. The uppercut has to stop at the medial campus, because if you go beyond, then there is what is called a rocker deformity. So some people do a brain stick fracture or some people do a complete fracture. Then the mobilization of this bone is done, and after that, then another osteotome is inserted by lifting the skin along the septum. Then you do what is called as a paramedian or a median osteotomy on the right and on the left, and a similar lateral osteotomy on the done on the opposite side, and a transverse osteotomy at the level of the medial campus will mobilize the whole lateral wall, which will be aligned properly in a proper triangular fashion. So this is a postoperative picture of a patient who has got a mid-columnar incision, and after closure, you can see that it's almost an invisible scar. You can see the base, it is an equilateral triangle, and the tip is defined. When the root of the nose, dorsal, everything is clear, the ala of the nose is corresponding to the medial campus. So this is an invisible scar which many patients are very much worried about. They can be convinced that it's not very difficult if proper closure is done. So any graft can be inserted in external rhinoplasty under vision, and it can be anchored with sutures so that it does not move. And for a graft, we almost always prefer a patient's normal tissue, either a bronchial cartilage or a remnant septal cartilage if present, or a rib cartilage. The concern with rib cartilage is harvesting the rib cartilage about 5, 6 or 7 synchondroses, and then there is a problem of warping of the rib cartilage, which can be done by taking 2 pieces of cartilage and aligning it together so that the warping is less. So after all this discussion, I have come back to the objectives, in which what we have done is the patient had a deviated nose, a nose along with the septum, this lower part. So what I did was we made an incision here, elevated the skin, then elevated the skin over the dorsum, over the right and left. Septal correction was done, brought it to the center. Osteotomies were done right and left, and the spreader graft was inserted on right and left. Spreader graft is a cartilage between the lower lateral cartilage, which is detached from the septum, so that the patient's nasal wall is open. So this patient had a nasal obstruction on this side. This got corrected by doing this alignment of the nose, the tip defining points, and this harmoniously it is achieved. This is another patient who had an injury to the nose during childhood, septal abscess, which was drained, and now he has come with a deformed nose where the dorsum of the nose is not properly formed. As you can see, the broad tip line is not seen at all. The broad tip line is not seen at all. On the right side, postoperatively, you can see 2 shiny lines parallel. So that is the goal of surgery, which we have achieved in this case. So I acknowledge my patients who have come to me for correction and then for the knowledge they have given to me for all this correction. And I thank you for your attention.
Thank you very much, Dr. Anand. Students, please type your questions in chat box.
Thank you.
Students, please type your questions in chat box.
So there is a question from Asha Ashok regarding spreader graft and a spreader flap. A spreader graft is a strip of cartilage about 1.5 to 2.5 centimeters length and 1 to 3 millimeters in thickness. This is placed between the detached upper lateral cartilage which is attached to the septum. The cartilage which is attached to the septum forms a narrow nasal angle. The narrow nasal angle also causes the internal nasal valve to get narrowed, so the patient will feel nasal obstruction. So, in a spreader graft, we insert the graft after detaching the upper lateral cartilage from the septum and then suturing it together and keeping a spreader graft also on the opposite side. So, initially, there is a septum and two lateral cartilages on either side. After we finish our rhinoplasty, two strips of cartilage are present between on either side of the septum to which the upper lateral cartilages are attached. That is a spreader graft. A spreader flap is one where you detach the upper lateral cartilage from the septum. Instead of putting a graft, the detached part is rotated inside and then it sutures together. That is called as a spreader flap. That is indicated in those cases where you have a narrow nasal angle, which is seen on diagnostic nasal endoscopy, the deviated septum on the same side, and patient is complaining of nasal obstruction on that side. And what are the steps for tip deformity correction? Tip deformity is mainly because of the domes of the lower lateral cartilages. The lower lateral cartilages, as you know, consists of lateral dome and a medial dome. Lateral crura and a medial crura, both of them are attached from a dome type of structure, which is seen as a tip defining point normally. So if there is any bifid tip where the domes are separated, or if there is an unequal cartilages where one side of the dome is more or less, then in the steps, what you have to do is first you have to define the cartilages on both the sides. In a case of closed rhinoplasty, marginal incision and an intercartilageous incision is given, and when the cartilage is delivered outside, called as a delivery flap technique, where you can see both the cartilages, and then you can remove what is called as cephalic trimming, or nowadays what they are doing is separate the vestibular skin of the lower lateral cartilage on the nasal side down so that the cartilages are pinched together, and then you have what is called as a domal suture technique, in which you create two surgical domes, and then if there is a blunt dome or the unprojected grouping tip, the velar cartilages are sutured in such a way that they define tip defining points, or if it is not enough, then you have to take a piece of cartilage and put a cartilage augmentation graft. If there is any other problem where the tip is over projected, then you have to do what is called as a lateral crural overlay or a medial crural overlay, or there is what is also called as crural steel technique, where the crura are enhanced by lengthening on one side, either in the medial or lateral. Augmentation rhinoplasty. In augmentation rhinoplasty, what we are doing in the case of saddle nose, augmentation rhinoplasty consists of increasing the dorsum of the nose, defining the dorsum of the nose, Then if there is any broadening of the nose in cases of nasal injuries which are not treated properly, then if there is broadening of the nasal mid-third, upper third, then you have to do osteotomies, bring the two lateral walls together, and then if there is a columnar retraction because of injury from the front, then you have to put a columnar strut so that finally when we create the whole nose, the proper nasofrontal angle, nasolabial angle, the nasal cavities are all put harmoniously together. So augmentation rhinoplasty has got all these 4 steps in addition to increasing the dorsum of the nose. Rhinoscleroma, as you know, is a chronic granulomatous disease where is granuloma formation, and then the nose in rhinoscleroma is called the hydra nose. So in such cases, what we have to first find out is whether the disease is completely arrested or not, and then there may be a chance of necessarily removing the skin of the nose. In those cases, depending on plastic surgery, you can take a forehead skin, a forehead flap, and then make the dorsum of the nose. An internal splint is used in those cases where the cartilage, septal cartilage is severely scarred, and if there is complete buckling of the nose, and when we release all the attachments, and if there is a doubt that the buckling of the cartilage can occur again, then we have to go behind, remove the perpendicular plate of the wall, make it straight, take thin bony strips of that, and then make small holes, and then use it as a internal bony splint at the level of the septal cartilage so that the cartilage does not go back to its normal preoperative state. That is one internal splint we can use. Reduction rhinoplasty is done in those cases where the patients have got what is called a tension nose, in which the nasofrontal angle is decreased, the tip, the dorsum of the nose is much more than normal, or if there is a hump on the nasofrontal angle, if you see the dorsum of the nose from the side, if there is a hump, then you do what is called a reduction rhinoplasty. In the hump, it can be cartilaginous hump or a bony hump. Then if it is a cartilaginous hump, with a right angle scissors, you can cut the cartilaginous part, and the bony hump can be removed by using an osteotome. Once you do this, then there will be what is called as a open roof deformity. For that, you have to do osteotomes on the lateral side on both the sides, and then medialize the two bones together and creating a dorsum which is normal placing. And if there is any small spicule that can be rasped, or to camouflage it, you can use soft tissue so that the dorsum is acceptable. Am I audible?
Yes, sir.
Okay.
Okay, so thank you very much, Dr. Anand, for this lecture, and thank you very much, students, for joining us. Good night.
Thank you once again.